welcome to another edition of CVision International's Thought Leadership Podcast. Today, we're very pleased to welcome to our program Janos Hajagosvv, and he's joining us to talk about healthcare IT, challenges of analytics, and data privacy issues in healthcare. Janos, welcome.
Thank you. Hi, my name is Janos Hajagosvv. I am the Chief of Data Analytics at Stony Brook Medicine. I also am a research assistant professor in biomedical informatics at the university. So my role, I do operational research and education around healthcare data.
Thank you for joining us. So tell us a little bit about Stony Brook Medicine. How big is the place? What kind of enterprise size you're running? And what are some of the big challenges that you have?
So Stony Brook Medicine is part of the State University of New York. So it's one of the SUNY systems. We're out on the eastern end of Long Island. We have a large main campus, approximately about 600 beds at the main hospital, and then we have two other facilities on the eastern end of Long Island, Southampton and near Greenport. And we're an academic medical center, and that brings some unique challenges. Being an academic medical center.
On the one hand, you've got patient privacy. On the other hand, you want to share data with other researchers, and that's of course there is a dichotomy there. So the last year and a half probably has been particularly challenging for you guys. Demands on bandwidth, demands on telemedicine. Can you share with us some of the details about that?
Yeah, so it was definitely challenging. I think we had a little bit of more time than maybe hospitals in New York City, maybe a week to get ready. But when COVID, we had the hospital here became almost overrun in early March, April, and into May. And it put a lot of stress on doing some of the data analytics. And so there are questions that were being asked in areas of the data that we weren't as familiar with. For example, on things like ventilator settings, which were hidden, deep down in the database, and questions were being asked about like what specific type of ventilator and when were they put on the ventilator, and so we had to, as a team, scramble pretty quickly, and also because we were one of the first hospitals to deal with COVID in the U.S. at a large scale. We were involved in research and trying to answer some basic questions like who's at most risk for COVID, how do patients progress through? And we published a paper on that pretty early on. So we were pretty active in doing this, and then also making the adjustments to working remotely.
So that's kind of an unusual use case for you guys, correct?
Yeah, was an unusual use case. I mean, we had been building a lot of the architecture to extract data out of the EHR. And I think one of the things that people that aren't familiar in this field is that the data, there's all these different systems. There's electronic health. There's the main electronic health record. There's the PACS system for the imaging. There's separate systems for pathology, and all these different systems. Some data goes to the EHR, some does not. So we've been working pretty intensely over the last several years in building processes to extract the data out but usually we start a project, we'd work on it, a month, 2 months. But in this case, we need to have turnaround of, in a couple of days. So that was definitely a challenge to be able to, bootstrap what we had and be able to answer the questions that were being asked.
So when you try to balance privacy, security, and also the need to access data rapidly, how do you overcome those challenges, especially when you're under such stress?
Yeah, so in terms of, I think it's having the correct environment set up. And I think this is something that I been involved in data analysis in healthcare for almost 10 plus years now. I think if you build an environment that researchers and data scientists want to work in, and that has all the tools they need and is secure, then you can, that takes away a lot of the issues, and sort of it's like a secure environment where you can work on the data. And you have, when you're doing these first steps of the data analysis, you really have to be able to dig into the data. And once you sort of validate it and verify the data is correct, then you can start doing things like de-identification processes where you try to obscure the privacy of the information so that it can be analyzed on a larger scale by other people. Yeah.
So how much automation are you relying on to make that happen? And also, what kind of machine learning and AI use cases are you applying to make that easier?
Sort of, it's still, unfortunately, it's still potentially more manual than we want to be, so we just actually released a large data set of radiology images through the NIH, and that's publicly available now that you can analyze on COVID patients. And, we worked with our data scientists here, and, we had to make sure that, for example, cell size limitations, were met, and we were excluding information that could be used to be identified. So it's still a little bit more of a sort of art than science. But I know there is definitely, and especially when you get into things like notes and things like when we did the images, also you have to worry about things being like burned into the images, and then also all the metadata associated with the DICOM file. So unfortunately, it's still a manual process. I mean, and it would be, I think that's an area where tools, and I know there's development of tools that are improving it, but you always got to validate it. It's, you never know where patient information could show up sometimes in the most, a place you're not expecting it.
And obviously, privacy rules being what they are, and HIPAA fines being what they are, that's an ever-present concern. Even if you're making an honest mistake, if patients' privacy is impacted, obviously the impact falls back on the folks handling the data. I'm curious, with data federation use cases being so prevalent and the need to share data in such a large fashion that you guys have certainly been exposed to in the last year and a half, how much role does the cloud play in it? Obviously, we're aware of the data silos. You talked a little bit about the fact that the data lives in all these different systems. Where does the cloud play a role in the EHR and then PHI and kind of management of data in your space?
So in terms of the cloud, I think there's a lot of great, there's a lot of great tools that have been made available in the cloud for data analysis. And, people want to use those tools, right? And, it's so easy to you bring up an environment and you only spend, $5 and you have a cluster, right? And it's you can do all these amazing analyses. But in healthcare, we have to make sure that, that is done in the correct way, right? And it's very easy in the cloud. Cloud makes everything very easy, but we have to do it in a way that is secure. So it does take a longer time to implement and get all the sort of legal aspect of it and the privacy aspect, and go through with our, CSIO to make sure that it actually is a secure environment. Mm-hmm. So that's definitely a challenge. In terms of data federation, we're working with, one of the things that we do is we're submitting our data on COVID patients to an NIH consortium called N3C, which is collecting data from all the major academic medical centers. And they're using a cloud-based platform for that. But in that, there's a very sort of detailed process that data gets shared. And there's different levels, and everything has to be approved. We have to get the IRB approval. So there's a lot of layers of regulation involved.
Has any automation been introduced into those processes, or are you guys still dealing with a lot of that manual overhead?
I think the platform that they're using does sort of have very good fine-grained control in terms of the access and the IRB, and making sure it's that we have that each project has a very specific purpose. So in these types of projects, it's not an operational project, it's a research project, and different rules apply. So in the research, you have to make sure that there's an IRB that says that that what you're doing, you describe what you're doing, and it gets approved by a board. Mm-hmm. So that's definitely, but all that is kind of built into that system. So it does sort of assist in the process.
And when you talk about IRB, for folks who are not familiar with the term, can you please define that?
That's the Institutional Review Board. So as we're working with medical data, and specifically at different levels. So sometimes I do work in an operational sense, that we're asking questions about, patient flow or different diagnoses of patients. But if we're a researcher looking to answer a question that's kind of global, then they have to get approval from the IRB to make sure that it's a valid study. So there's a lot of, we use a lot of healthcare data, but there's a lot of sort of regulation and safeguards that are in place to make sure that people are using the data correctly.
How much role does data architecture and data governance play in what you do, and how much of that work happens up front, where you actually want to know, you actually know what kind of data you're going after, and then you go out to get it, versus you already have all this data, it's sitting out there, and now you're trying to pull it in.
No, it's yeah. So there is this sort of, we have operational type projects where it's going to be, we're looking to see can potentially harness data for something. Like, for example, looking for findings in radiology reports. We had to be able to figure out, before we even did research, we had to be able to say, can we access this data? How many notes are there? And have sort of a description of that before we get involved with the IRB, the research board involved with it, and sort of describing a project. So there's different levels. And so governance always plays an important part as sort of move on. We're doing what's called a quality improvement study, which is it's a kind of between an operational and the research project. In this type of study, you're looking at like trying to answer like a patient safety question at your institution. And that's a different level, and that requires approval from our chief medical officer. So there's different levels that we have to sort of go through, and we're tracking through the provenance, right? And we also have to track, in terms of data and security, we have to track who accesses the system. We have the central management of that. What type of queries are they running? And so all this data needs to be collected and managed.
So for you, security and privacy, is that a gate, or is that a separate function, or is this just inherently included in the way you guys manage data?
It has to be inherently included in the way we manage data, because it's so fundamental working in this area.
From an organizational perspective, I'm curious how that works practically, right? Every organization has different ways to approach security and privacy. And of course, we have chief privacy officers, chief information security officers. Where does that function fit within Stony Brook?
So we do have I think it's been evolving since when I came here. We had one person, let's say a HIPAA person, right? And over the last, let's say 5 or 6 years now, we have a CSIO. He's also been expanding his staff as we do more projects. And so it's sort of been expanding that sort of data privacy, but it's inherent in what we do. We always, making sure that we're working on secure systems, and sometimes it does cause limitations, right? And we have to sometimes be patient and sort of like making sure all these policies are in place. And we also work with people, students, and we got to make sure that they have all the correct training to access the data, right? But we try to also separate data. We have de-identified data also that allows students to work with and sort of learn how to analyze healthcare data, because that's one of the issues. I think this is one of the issues here, is that there's not that many data sets available that are sort of as rich as what you would want and learn from. So that's one of the things, sort of educational thing, is bringing de-identified data sets that students can work with and learn from. And if they make a mistake, it's not it's not patient data, so it's not as, but it has the same structure as healthcare data. So it's definitely trying to pardon off and reduce risk. I think we're always trying to reduce risk in the process.
Mm-hmm. Risk management occupies kind of an overarching function within everything, and just included as a component of everything you do.
Yeah.
That's great. We do see a lot of use cases out there, certainly in the corporate world, where security is sort of a separate function. It's either bolted on after the fact, or it's just run as an adjunct function, and or acts as a gate, kind of a final approval authority before something goes into production. Where for you, it just has to be an inherently included component of
the whole. Yeah, because we have. There's different levels, and even on the educational part, right, and the research part and the operational, we always have to separate those out.
So let's talk about data bloat, right? Obviously, you have retention requirements. Patient healthcare data has to go at least 5 years back. What does that do for you in terms of storage, obviously, but also does that push you into the cloud at a faster scale? Does that mean data federation use cases get a little more interesting or a little more challenging just based on the bandwidth requirements alone? And now, of course, telehealth and telemedicine and all the remote work. Curious about that.
I think data. So data retention. I think we want to keep data. Even there's sort of the legal thing that you have to keep data for a certain period of time. But we want to keep, for analytic and research purposes, we want to preserve data as long as possible. And so the data volumes have been growing pretty significantly. I mean, so when I first started mostly working on sort of claims systems, so you would have things like diagnosis codes and procedure codes, and maybe for a single visit, you might have, I don't know, 10 to 12 codes. And that was, the diagnosis codes were the biggest data sets. But now with EHR, electronic health records, you can imagine all the data that's being recorded, right? So you have, every blood test, every oxygen reading, every time an assessment, a respiration assessment is made, it's all being recorded. So now, a single patient is generating a large volume of data, but now multiply that by the number of inpatient stays or the number of outpatient stays in a system, and now you're talking relatively, very large sets of data. And sort of, I think we've, struggled a little bit, going from our sort of internal architecture, right, and going to the next thing of moving towards more of a cloud-based secure architecture. And I think we're in that process of that transition. Mm-hmm. And it's definitely it's definitely taking some time to make that transition. But we try to do it in steps. And so we have a pilot project where we're working with de-identified data in the cloud, and doing analysis and doing sort of getting ready for that next step.
So in terms of big data analytics and using things like data lakes and Hadoop clusters, you mentioned clusters before.
Yeah.
Where are you on that? And also, I'm curious about the innovation lifecycle. How does that work within your space, and who drives it? Is it the medical professionals? Is it the data professionals? Is it a combined effort? Curious about that.
Yeah. So so sometimes it's our outside vendors. We use a platform from Cerner's electronic health record vendor. We use a platform from them called Healthy Intent, and that was running initially in their data center in Kansas City. They moved that to that we were able to do the sort of a migration of that service into AWS. And since Cerner, we have an existing relationship with Cerner in terms of we have all the security and privacy in place with that vendor, it was easy for us in that case to sort of do that migration. And now we have it's a more reliable system that we have running in AWS for that population health platform. So definitely when we can partner with a vendor, that's then it's a lot easier to do that that transition. Mm-hmm. And I think because the data volumes are growing, and the amount of we're not even sort of capturing all the data, images, right? All the monitors, we're only capturing sort of sample points, right? And that's still a lot, right? So the future, I think, is even more and different modalities of images. I can't really see that without the cloud, we're not going to be able to do the sort of next generation of analyses that people are looking to.
Obviously, the executives are going to have to embrace the idea that the cloud is the way to live, right?
And also, like I did, and talk about machine learning. We're involved, with machine learning and things like, we do basic machine learning type models like logistic regression, random forest, but we're also moving into things like deep learning. And I think in the cloud-based environment, having the ability to, like, say, turn on a machine which has GPUs on and do the processing for a period of time, and do like optimized learning, is important too, right? So it's, instead of having to make super large investments, right, in sort of in the in infrastructure in the cloud, we could sort of rent and do things in bursts. And I think that's something that I find in healthcare analytics. There's a lot of kind of burst type projects where we'll focus on building a model. It's not like we always need to have 100 GPUs ready at any instant, right? I mean, or using that all the time, but we'll use it for a period of time and then we'll shift to work on a different project.
That's understandable. So I'm curious about some of the more future-facing technologies that you guys might be looking at enabling, and again, machine learning, machine vision. So I know a project that the Memorial Sloan is running called Page AI, where they're looking at imagery and trying to understand if they can actually supplant human analysis with machine-based diagnostics. Curious if Stony Brook is looking into anything like that, and what those efforts might look like in that area.
Yeah, so this is about putting more of my research hat on as being like a research faculty member. We have faculty members that are sort of developing those sort of next systems, right? So I still think it's a very research focused. Like, for example, looking at one of the researchers here is looking at CT scans and trying to detect lung nodules in the CT scans for cancer detection, right? Building algorithms for that. Another set of a pretty large research group here is looking at pathology images and looking at trying to develop image features to better predict prognosis. So it is an active area. We, as sort of the chief of data analytics, I work with these groups to try to make sure that they can get access once all the legal and all the policy stuff is in place and IRB is in place to get access to these systems. A lot of the challenges are these systems aren't designed yet for. They like to keep the data inside of them. Getting the data out can be a challenge.
Mm-hmm. So, of course, obviously, all of that is meant to increase patient safety, patient outcomes. How close are you to the patient outcomes? Right. So you work in the data, you work in the research data. Are you able to see the entire life cycle end to end, and are you able to see the effect that your data analytics capability has on those patient outcomes?
Yeah, a lot of we'll do. It depends on like a project, right? We'll have a specifically focused project, right, and then we'll sort of develop a research product or a quality review product, and make presentations to higher level C-suite people, and provide sort of feedback into system. And I think a lot of times it's educational, because we have showing the data and showing it accurately is definitely an informative process. So they learn from what's actually happening. So another sort of, I think, sort of way to communicate how the organization is functioning that we're sort of developing, and we have that process in place. We've seen with some of the projects, we did a readmission project, and I think a lot of times a lot of things that in doing the research and putting these projects together, we notice areas where there is data issues, and sort of in our modeling, and we say, okay, for example, we're looking at for readmissions, looking at the source of where the patient came in from, right? And that's an area that once we were doing the research, we realized that it wasn't being collected in a systematic way in the EHR, and that even went down to the people that were doing the interviews when the patient comes in. They didn't have we had to do an educational process for them. So definitely in that thing, when we presented the data, it definitely made institutional changes. That if someone's coming from a nursing home, it's good in which specific nursing home they're coming from, and that's important. And then when they're so that when they're going to get discharged, that all the sort of planning and process is in place.
So data insights drive real outcomes. You see that end to end, and of course, there's that bidirectional relationship where you see outcomes driving innovation back into your space, and then asking for better insights. And then, of course, the mission couldn't be more clear in your space than anywhere else. You're not making widgets; there are actual live human beings that you're dealing with. And even though you're in the data, you're not there on the front lines actually doing patient care.
No,
that still carries through.
And I think I think one of the things in healthcare that's important is working with subject matter experts, like physicians that know the data, right? And we saw that when we were working on COVID. Trying to understand the different ventilator settings, right? You have to work with people that understand the data, because it's very easy to build a model that predicts something that's sort of obvious if you don't have sort of subject matter experts working with you in that process. That's important.
So how do you build that into your data models? I'm curious about that. And also, no conversation about AI and ML these days is complete without a conversation about ethics. So I'd love to know where that plays a role.
I think I think part of the important thing is managing the metadata around the data. So people aren't as familiar in the healthcare setting, getting everything aligned to standardized codes is critical. And that's something that's sort of maybe a little different than in other industries. That helps the process of sort of tagging and providing context to the data. So, it might not, for example, a laboratory test, very different, like point of care test versus one that's drawn in the lab. So these are important differences that have to be coded into the data. So that's, working with the subject matter experts and sort of doing those mappings is critical for making sort of, and then the other part is working with subject matter experts and validating your data, right? Validating what they're seeing. Is this the number of patients with X, right? Is that what they sort of expect to see, right? And sort of that we have to work very closely with the subject matter experts to make sure that what we're seeing in the data is correct. It's very easy to, the process for analyzing healthcare data is multi-step. So it's very easy that there's a mistake or and then you want to make sure that you're interpreting the data correctly in that process.
So I have a friend of mine who actually runs a large healthcare organization in the US, and he told me about a story where they had this pile of data that they had assembled, and they put on a big data lake, didn't really know what the use cases might be. And then they start running different pattern matching algorithms on it. They ran a couple of training scenarios on it. And next thing you know, they're surfacing kinds of insights that they really had no idea they would see. How much of that is prevalent in your world? How much are you surprised by some of the insights that occasionally you surface through that data?
I don't know if we're surprised. I think we try to work, I think we try to combine the data together and try to answer specific questions. Mm-hmm. So I think that's, I think, I'm not sure if we ever been surprised,
mm-hmm. So let's talk about challenges, right? And I know we're coming up on the bottom of the hour now, but what is the biggest challenge right now in your space specifically? And maybe not necessarily Stony Brook, but let's talk about electronic health records, PHI, and just data analytics in healthcare. And especially the challenge of the last year, obviously we understand, the pace has quickened, the demands are higher, bandwidth and et cetera, data bloat. But if you were to say, one thing that you care about the most right now, if you could solve it today or in the next 6 months, what would it be?
I think the biggest challenge is having clean data. I think that's really the biggest challenge that we're facing. Data that's sort of been slightly massaged and validated. That's probably the biggest challenge, and to do that at a scale, right? We can, before we might do a small project, work with a researcher, and through that process we'd get for that one specific project we'll get a clean data set, right? But how do we automate that process? How do we find algorithms that are going to do that, but do that at a larger scale? That I think that's definitely the challenge, and having that scale up, across, here and then across nationally. I think, I think with data, I think if we're not using it, right, it's not going to improve, right? So I think, we have to be using the data and asking questions of the data, and then that process starts the sort of kind of a life cycle, sort of getting back and improving, what we're recording.
How much role does technology play in that? Obviously, technology is central to what you do, but how much can you rely on technology? And do you see anything emerging in the next maybe 2 or 3 years that can really help address that concern with data quality? Sort
of academic projects. One of them is a data model called Odyssey, which was developed out of some joint work with the NIH and FDA, post-surveillance drug marketing. They developed sort of a whole set of controlled schema and controlled vocabulary for working with data. And systems like that, sort of integrate data from different systems and align them across into one vocabulary, I think is a key technology. I think there's a lot of automation that can be done in getting the data out of your system, right, and into one of these more controlled environments where you don't have to relearn every field name, right, when you're working a query, right? That it's sort of aligned to sort of a standard, right? And also things like FHIR is also important in that so we align our data system. I think there's a lot of interesting work that could be sort of done in automation And I think machine learning is going to play an important role in that, sort of mapping, for example, drug names. You can, sometimes the code is there, sometimes it's not there. And I think definitely machine learning in that process, sort of like matching and getting better matches, definitely an area I think where I see stuff improving and growing.
Do you see investments from the private industry and also the regulations that are coming from the policymakers? Where do you see the balance there? And can we expect that something will improve after the experience we've had in the last 18 months in the healthcare space, dealing with COVID, dealing with the pandemic? Do you see any improvement areas that are probably near term, maybe the next year and a half, 2 years, that can improve data portability, the connectivity of data, the exchange of data, support these research use cases, and drive outcomes forward?
The project we were involved with the NIH, where we kind of brought data from multiple sources together. I don't think we would have been able to do that like 5-10 years ago. And we used a cloud-based platform for that, secure cloud-based platform. So I think definitely that this ability to sort of combine data together is going to be important.
And it sounds like some of the emergency mandates allowed some of those connections to happen at a lot faster pace than usually, but hopefully that just continues to remain the way that we do business.
We have to do this in an ethical way, right? In terms of making sure that we're sharing data ethically, right? And that we're not, we're preserving patient privacy. So there's definitely challenges there. And there's a lot of interesting research in that area too, like in terms of generating synthetic data sets. So using real data and then sort of modeling the distribution of the real data, so you can generate data sets that you can work with securely, and then taking those insights and then applying it to the real data. So there's some interesting sort of research happening, sort of improving like how we utilize healthcare data.
And thank you for doing it. Thank you for being on the front lines of innovation and, of course, enabling patient care and enabling patient outcomes at scale. God's work, obviously, and here's hoping that continues. Thank you for joining us, Janos Hajagosvv.
Thank you.
You're a busy guy, but thank you for spending a little time with us in our audience. Thank you for sharing your insights. We love having you on. So thank you very much.
Thank you.